Welcome to Hand Surgery Resources YouTube video on mallet finger and mallet fracture. Mallet fingers were first described in 1880 by Sagan. The mallet finger has been described as a drop finger, mallet finger because of the mallet appearance of the end of the finger after injury, or baseball finger because of the propensity to injure the tip while playing baseball. When dealing with mallet finger and mallet fracture injuries, it's important to understand the extensor tendon anatomy on the dorsum of the digit. The two conjoined lateral bands combine to form the terminal extensor tendon, which is the structure that ruptures in the typical mallet finger injury. The incident data for mallet finger and mallet fracture show that there are about 10 new cases per 100,000 individuals per year. It is most commonly seen in the middle age group, and more common in men than women. The most commonly affected digits are the long, ring, and little fingers. The dominant hand is more often injured than the non-dominant hand. The mechanism of injury for the baseball finger is seen here. A baseball coming at a high velocity hits the tip of the extended finger, driving it suddenly into flexion. The immediate instantaneous result is rupture of the terminal extensor tendon. The immediate result is a dropped finger, ruptured extensor tendon, and the ball lands on the ground. In older individuals, particularly those with osteoarthritis in the DIP joint, much more trivial injury, such as tucking in a bed sheet, can result in rupture of the extensor tendon. The Doyle classification of mallet finger and mallet fracture injuries should be used to categorize these injuries and help understand and predict appropriate therapeutic options. The mallet finger can either be closed or open with tendon laceration. The mallet fracture can be either closed or open and should further be categorized according to the percent of articular involvement of the base of the distal phalanx. When evaluating the mallet finger and mallet fracture patient, one should also keep in mind the differential diagnosis. There are other entities that can cause the DIP joint to be in flexion, such as rheumatoid arthritis, Dupuytren's contracture, osteoarthritis, volar plate injuries with secondary swan neck deformity, flexing the DIP joint, phalangeal fractures with apex dorsal angulation, and Seymour fractures in children, which is really a transepiphyseal fracture, but can appear with a deformity suggestive of a mallet finger. The presenting symptoms of a mallet finger or mallet fracture include pain at the tip of the finger and the dorsum of the DIP joint, pain and swelling around the DIP joint, and a flexion deformity at the DIP joint. On examination, the signs of a mallet finger or mallet fracture include tenderness at the dorsum of the DIP joint, extension lag of the DIP joint, and swelling of the joint, with or without an open injury. This patient presented with a mallet finger in the context of pre-existing mild swan neck deformity in all digits. So you came in today because you can't straighten your finger?
Yes, I was at my daughter's batting practice, and she hit a line drive right back at me.
Hit you right here on the tip, I guess.
Yes.
Is this still tender these 2 weeks later on the top?
Yes.
Oh, okay. Right, relax. I won't push there again. Does this hurt on the sides?
A little.
Okay, let it go loose. Does that hurt you?
A little.
That hurts a little too, I assume.
Yes.
Okay, can you straighten it at all?
No, just
Try
a little.
Try a little harder.
Not much.
Not much. Okay, how about bending it down like you're making a fist? Okay, that's still working, but it still hurts on the top when I try to bend it. Imaging of a potential mallet finger can include ultrasound evaluation of the extensor tendon and DIP joint. X-rays are the most common imaging technique used in this group of patients. X-rays should include AP, lateral, and oblique views. This X-ray diagram shows a very small mallet fracture which is non-displaced and not associated with any tendency to disrupt the articular surface of the joint or sublux the joint. This X-ray diagram shows a larger, more displaced fracture fragment which may be associated with some degree of instability of the joint and a little disruption in the congruity of the joint. Some surgeons would recommend intervention, and others would treat this in a splint. This X-ray diagram shows a very large mallet fracture fragment associated with serious subluxation of the distal phalanx. In fact, this is essentially a fracture dislocation of the joint and will require some intervention either percutaneously or open. Over 90% of mallet finger and mallet fracture injuries can be treated successfully with immobilization to allow the fracture or tendon to heal. This classic stack splint is often adequate immobilization and will allow the injury to heal appropriately. Okay, I think you've hurt your tendon. We're gonna let me pull it up straight. Okay, and we're gonna put this splint on you, and we'll use this. Can you hold that there for a second, please? Okay, and we're gonna tape it up. Okay, now you see in this splint, you can still bend this knuckle here, we call the MP joint. You can still bend this one. So do like this for me. You see how you can bend there?
Yep.
That's important because we don't want that to get stiff, but we don't want to bend this. So you can take this off, but when you do, I want you to hold your finger like that so that you don't allow it to stretch out. Okay. The tendon has been sort of torn apart, and we're trying to push the edges together and hope that they'll heal so that the finger will be relatively straight when it's sitting calm. That's going to take 4 to 6 weeks of full-time splinting. Okay. Now, if you wear this one splint all the time, it's going to hurt your skin in certain places. So I've got a foam splint, which you can put on the bottom or the top. I've got a little splint with aluminum and padding. Very good for typing. You can put it on the top, but you can also wear it on the bottom. By switching the splints in their position, you can give different parts of the skin a break. Okay. But remember, you need it to be straight for 6 weeks. And then after, we'll have you wear it just at night. And then during the day, a little Coban type tape to support it when you're doing activities where you might hurt it. Okay. On rare occasions, a closed mallet finger may be internally splinted with a K-wire as seen here. This was a right-handed surgeon who had a severe mallet finger of the fifth finger. With this K-wire, which was left under the skin, the surgeon was able to scrub. The K-wire was further protected with the cylinder splint that could be gas sterilized and placed over the prepped finger and under the surgeon's glove. The pin was left in place for 4 to 6 weeks. When a mallet fracture is associated with subluxation of the distal phalanx distal fragment, and there is a large intra-articular mallet fracture fragment, surgical intervention is indicated. Here we see this problem being managed by closed reduction and percutaneous pinning. The first step is to place a pin longitudinally in the distal phalanx distal fragment and then reduce the dislocation. Next, the distal phalanx distal fragment is reduced and a second K-wire is passed through the center of the terminal extensor tendon just proximal to the mallet fracture dorsal fragment. This second K-wire is used as a lever to manipulate the fragment back into an anatomic alignment with the distal fragment and the DIP joint. Next, this maneuver is reviewed in an anatomic video. The pin through the skin and then through the middle of the tendon, and then lever the pin to push the fragment back in place and then drive the pin into the middle phalanx. Once the dorsal fragment is levered into position, the longitudinal K-wire is passed into the shaft of the middle phalanx. Sometimes this can be done before the levering, but one must be careful not to place the longitudinal K-wire in the space where the dorsal fragment needs to go. Once the longitudinal K-wire is in position, the levering K-wire is adjusted to make sure the reduction is near anatomic as possible, and this K-wire is passed obliquely through the head of the middle phalanx and into the volar cortex of the shaft of the middle phalanx. The pinned mallet DIP fracture dislocation should be protected with splints for 4 weeks. At 4 weeks, the pins can be removed and splinting continued for an extra 2 weeks before switching to nighttime splinting. Here we see the initial steps of an open reduction and internal fixation of a mallet fracture. The longitudinal pin is in place, and the fragment has been identified at the tip of the hemostat. This diagram shows the overall details of an open reduction and internal fixation of a mallet fracture. Note the longitudinal pin keeping the joint aligned anatomically, the pull-out suture which is holding the fracture fragment in anatomic alignment dorsally. These steps are reviewed in the specimen dissection in the next video. This dissection is done on an older specimen, so there is arthritis present, which means in a real situation this might have been treated with arthrodesis. The mallet fracture dislocation of the DIP joint we have made in our anatomic specimen.
So with this specimen, we're going to demonstrate the open reduction and internal fixation of a mallet fracture. We've made a incision here along the edge horizontally and then back out toward the appendicular fold. As we open this incision, we see the extensor tendon. Here's the terminal tendon right here. Here's the conjoint tendon back here. We've mobilized this tissue a little for demonstration purposes, but as you see at the end of the terminal tendon, there is a mallet fracture which has been pulled out of the base of the distal phalanx. We place the pin in the distal phalanx. We make an entry hole into the head of the middle phalanx. First step is to place a pin in the distal phalanx and keeping it as volar as possible. And then we can draw it out. Then we reduce this PIP joint, and now we're going to manipulate the pin into the hole and then advance it into the middle phalanx shaft. We don't want to go into the PIP joint, so make sure the PIP joint is moving. Okay, so now we have the distal phalanx pinned to the head of the middle phalanx. We have our fracture fragment attached to the tendon. Next, once the pin is in place, we're going to place the mallet fracture back in its anatomic position and get ready to use a pull-out suture to secure it here. The pull-out suture in the terminal tendon, some people put this through across the top and through the bottom, but then the suture is pulling underneath the fragment. I like to put it through the tendon and then go basically across the bottom of the tendon and then back out through the top. Now the importance of this step then is that after we pass this pull-out stitch down through the fingertip, it's going to be resting over the top of the tendon and over the top of the fragment, pulling the fragment down into its anatomic position. Now we've used a Keith needle to pass the pull-out through the base of the distal phalanx, slightly obliquely from dorsal to volar. And before that, the suture has been placed in the terminal extensor tendon. Next, this remaining end will be passed through the bone as well. Usually we use a K-wire to make a drill hole here first. And with the Keith needle, we push this down through the finger as well and pull the last part of the pull-out into place. Relying on the pull-out to pull the fracture fragment into its anatomic position in the base of the distal phalanx. Supplemental sutures will be used where possible to help secure the tendon in this anatomic position. The pull-out suture, which we see here coming up from the bottom of the finger, will be secured over a button in the bottom of the finger. The wound will be irrigated, and then our skin flaps closed to complete. We'll bend the K-wire so it is up over the tip of the finger. Securing the pull-out over a button on the palmar side of the pulp, the incision has been closed with interrupted 5/0 nylon sutures, and the K-wire has been bent over the fingernail. The finger will then be supported with a splint for 4 weeks to allow the fracture to heal. Approximately at 4 weeks, or between 4 and 6 weeks, the pin will be removed and a supplemental splint used before starting any DIP motion.
Final AP and lateral fluoro Images of the open reduction internal fixation of the mallet fracture are seen here. This severe injury was secondary to a table saw injury to the left hand. This patient sustained open, severe mallet fractures to the index, long, ring, and little fingers simultaneously. This X-ray shows the open mallets of the index, long, ring, and little fingers, secondary to the table saw injury seen above. When treating mallet finger and mallet fractures surgically, one should anticipate complications such as adhesions, neuroma formation, infection, recurrence, persistent extension lag, and post-traumatic arthritis. Before concluding, we should remember some key educational points related to mallet finger and mallet fractures. Acute traumatic swan neck deformities must be carefully examined to determine if the deformity is secondary to a mallet finger injury or secondary to a PIP joint volar plate injury, or both. All potential mallet finger injuries should be x-rayed with AP lateral and oblique views obtained to rule out mallet fracture and to determine the size and displacement of such fracture fragments. Effective splinting of the mallet finger injury requires a reliable, conscientious, and cooperative patient. Splinting 24 hours per day should continue for 6 weeks and be followed by 2 to 6 weeks at night. Protecting the finger with tape during the day for vigorous activities after continuous splinting is advisable. Patients must avoid trying out their active DIP extension to avoid disrupting the healing of the terminal extensor tendon during the splinting process. When splinting the DIP joint in extension, avoid excessive hyperextension that causes blanching of the dorsal skin at the level of the DIP joint. The PIP joint does not need to be immobilized when splinting a mallet finger or mallet fracture. Splinting the DIP joint in neutral extension with a K-wire left under the pulp skin can be useful if the patient must do activities like surgery. A gas-sterilized, thin, custom tube splint should be used under the surgical glove to protect the K-wire from bending when this option is employed. Alternating splint types and position on the DIP joint area can help minimize skin problems associated with prolonged splinting. The initial mallet finger extension lag can vary from 5 to 85 degrees. Remember, a small amount of extension lag can progress if a mallet finger is not splinted and recognized early. Late presentation is not a contraindication to splint treatment. Successful splinting outcome for mallet fingers can be expected for most patients, but poor results can occur secondary to poor cooperation and inadequate immobilization. Lacerations that cut the terminal extensor tendon can also cause a mallet deformity. These injuries should also be considered an open joint injury because the capsule and extensor tendon are confluent at the level of the distal DIP joint. These injuries require acute surgical repair. There is no agreement and consensus on the indications for surgical treatment for closed soft tissue mallet finger injuries. Surgical repair of the terminal extensor tendon is frequently unsuccessful because of the thin nature of the tendon and shredding of the injured tendon that cause the sutures to pull out easily. Additional key educational points include: any surgical procedure should be done with care to avoid damaging the germinal matrix, which begins just distal to the insertion of the terminal extensor tendon. Surgical repair of the mallet finger is considered if the dorsal fragment fracture is 20 to 30% of the articular surface of the distal phalanx and the joint appears unstable. Surgical repair is indicated if the large distal phalanx fracture fragment is subluxed volarly to the head of the middle phalanx. Chronic supple mallet fingers with PIP joint hyperextension and DIP extension lags can be treated with the Fowler central slip release technique, but the precise procedural details described by Bowers and Hurst must be followed. Chronic neglected mallet fractures with large interarticular fracture fragments may require DIP joint arthrodesis. In children, a transepiphyseal plate fracture, the Seymour fracture, can mimic a mallet finger injury and must be recognized as a separate, distinct entity. Thanks for watching Hand Surgery Resources YouTube video on mallet finger and mallet fracture. For more information, log into www.handsurgeryresource.org and see our extensive online text, Hand Surgery Source, version 3.0. In addition to accessing information at Hand Surgery Source on the web, you may also access Hand Surgery Source via our new app, The Hand Surgery Source app is available at the Apple App Store and at Google Play. We hope you've enjoyed our YouTube video on mallet finger and mallet fracture. Thank you.